Well, we have a special guest today. John has been a patient and more than a patient. He's part of the family. Um, he had a heart attack and a bypass many years ago. And I like to say he's not dead yet. He's one of those individuals that really has worked hard on prevention. And I'm pleased that he's part of our repertoire of 100 really good stories we all need to listen to. So let's hear some more.
Yeah, quickly just want to share this. We have this Olympic going on right now. We give people points for doing healthy activities, and in February we had the push-up month, and we had some other health athletes, I call them, from our patients who submitted some of their activities. You can see some here. I'm not going to reveal who had the flavorful chicken at the bottom. They may be in the webinar with us tonight, but jokes aside, it's a wonderful thing to have people see people do a variety of different things. You can see them here. And speaking of variety, we have mobility march in our Olympics and fall prevention, where we're trying to do some balance exercises, one leg stands to see who can last the longest. More than 10 seconds is the threshold. And yeah, we can see Ross leading the charts here, and we're gonna update this every little bit. Anyone's interested to join, there's a link of how to join in the description of this video.
So February was Mental Health Month and push-ups. So we did like 2,000 push-ups in that month, and I think push-up is one of those exercises I got to push myself away from the fridge, um, and also doing some push-ups, and now we have many health challenges. So thanks very much for Rad for spearheading this. Next slide, please.
Yep, just wanted to show a few pictures of you exercising. Yes, that recent one at the bottom left, working the core a little bit. That wonderful quote you mentioned, and a picture of us just today with John and the team.
Yeah, I think I have the greatest job in the world. I get to read really fascinating, interesting people, work with young people, old people, and what I've learned is success is the sum of small efforts repeated day in and day out. Another neat quote is life is 10% what happens to you and 90% what you do. And I think for really most serious tasks in this world, you need a team approach. Here on the top hand corner, there's just a gentleman who's 88 years of age. He can do more push-ups than myself. I think I stopped in early 20s and he kept going and he was really nice to coach me. Speaking of coaches, Mondays and Fridays, I thank Dalton at Dundas Physio. I pay him big bucks to beat the shit out of me, and he does a really good job of helping me actually treat my fall prevention, trying to build some muscle, um, try to have a good time with the team there. And what I learned from Dr. Tia Rad, I think you got me started on this, and all our kinesiology students have reminded us is that between the age of 30 and 70, you'll hear this over and over again. You can lose half your muscle mass. And so is don't get old, but if you're going to get old, age well, and we'll show you some good ideas about how to do that well. And I'm blessed with the greatest clinic in the world because of working with young and old people. And this is just a picture of the crew here today. And John came. I told him to come a little bit early, and like normally, he's waiting around for me. What else is new? But it's been a real pleasure. I have the world's greatest job. I get frustrated sometimes, but I feel really fortunate to be able to still contribute. And I guess I wouldn't make it to Trump Tower today because if you go to Trump, you have to wear a suit. I'm not wearing my suit. Uh, I'm not shaven. I need to take a shower. I think what happened is that I finished work here on 11:30 last night, and I just basically fell asleep on the couch and started again today. So if all goes well tonight, I'm going to head to the gym on the way home. But we'll see what time we finish, or maybe some stairs. I'm one of the two. So I hope to do something on the way out tonight. And I'm going to be at Dundas Physio tomorrow morning at 6 o'clock. Um, we're playing a game. What's the game?
Okay, basically the game is Dr. Kearney quotes and also health facts about lifestyle. So we're gonna get everybody. So we're gonna get John, Dr. Kearney, and all the volunteers um, to guess whether this is true or false. So the first one is, "May the odds be ever in your favor." Has Dr. Kearney said this quote before? What do you think, John?
I haven't heard that one. I have not heard that.
I don't think I remember saying that
I,
one.
I heard that one. I haven't heard that.
I was going to comment that I think I've heard something similar, but I think maybe I have said it. I remember we had a COVID webinar where I said something along this line, but I'm sure I wouldn't be surprised if he said something similar as well. What's the answer?
That's from the Hunger Games. I'm going to say no. Did I say that?
I don't remember.
Oh, close enough. Okay,
Okay.
go ahead,
Alright.
Morgan.
So
That I agree with. You don't know how much time you have left. I agree with that.
yeah.
Dr. Kerner has said that.
Yeah,
So
yeah,
the odds in your favor. May the odds be ever in your favor is actually from the Hunger Games. So Dr.
yeah.
Kearney is not a Hunger Games actor.
And I think remarkable series of films there.
Okay, next one. If someone is expressing concern about your health and you're ignoring it, that's a worrisome trait. And if he said it, bonus points for guessing when he said it.
My guess is that I don't recall the exact words, but when I come here for a doctor's visit, he said something similar to that.
Yeah, I get frustrated when I don't see people working at their health. I get chest pain, palpitations, and I get frustrated. So I don't mean to be that way. That's from a behavior modification point of view. I'm supposed to try to inspire, put doubt, and but yeah, I'm trying to learn to control my emotions better. One thing I've learned is that we have 40 to 8,000 thoughts most days through our brain. Most of them are unpleasant, repetitive. So I'm learning to laugh at myself a little bit more. So what's the answer here?
The answer is yes. He actually said this in the to drink or not to drink alcohol webinar, but I think this applies to just everything with your lifestyle. So yeah, great job. Next one. The best time to stop taking your cholesterol pills is the day after you die. Has Dr. Kearney said this before?
Dr. Kerner is always asking me if I'm keeping up with my cholesterol pills. So I agree with the statement. I think he has said that.
Yeah, that's gonna. I think it's gonna be on my team's tombstone. The best time to stop your cholesterol pill is the day after you die. You want to make sure you're really dead, because you can actually lower your risk of a heart attack up to 60% by being on cholesterol pills. Isn't that amazing? 60%.
Yeah, I have a quick proposal. So we should put this on a shirt, and then we can have you wear it. That'd be a good idea as well.
Sounds good.
Okay, I think this is the last one. The optimal LDL cholesterol for high-risk patients is less than 2 millimoles per liter. True or false?
I think it should be even shorter. I would say less than 1.
I like this guy. So we're gonna say that's false. There we go. Yeah, less than 1. The 3-1-1 rule. We'll talk about that in a second.
Okay, great. So let's get into the webinar and kind of introduce John.
All right. Well, first, thank you, John, for joining us today in this webinar and participating in the 100 Patient Story Project. So we have some on the slides here, but do you want to introduce yourself to the audience?
My name is John. Last name is Kersley. I'm born in Hamilton, raised in Hamilton, and I taught school for over 30 years, and I'm still part of University of Waterloo because I do math contests.
Oh, wow, that's cool. I used to participate in those. Yeah.
Maybe I marked your paper.
Yeah, but besides that, he is very close with his family, and he's he used to be a very active person and still tries to be, enjoys walking, and also used to ski and skate before his knee replacement surgery. Yeah, let's move on to a bit about his health background.
So John had a heart attack in 2011, and he then had a bypass operation. And I remember back in 2011 or so, if you had a bypass, it means you had severe blockage. It's usually all major arteries. It's a catastrophic event. It's failed prevention. And if you got 10 years, life was good. And I keep saying now is that John's not dead yet. And one of the things is that controlling risk factors is really important. Type 2 diabetes, if you have type 2 diabetes, defined as a hemoglobin A1C greater than 6.5 on at least 2 blood values, that means each year you're 40% more likely to have a heart attack or stroke. blood pressure, it's kind of interesting, is that we're learning that the ideal blood pressure is close to 110/70. And we have to watch out is that controlling blood pressure is important, but if we control it too much, we can get people dizzy at points in time here. And this is actually a neat little slide, how to measure blood pressure. First of all is blood pressure, it's a summation of all your blood pressure readings in a relaxed state. You see us doing some exercise. If you're lifting weights, your blood pressure during that event is probably 240, 270 over 130. If you go back, you keep that slide there for this is a meta-analysis of over 600,000 patients. For every 10 millimeters reduction of blood pressure. So if your systolic blood pressure is 130, you go down to 120, you basically decrease the risk of a cardiovascular event by 20%, decrease stroke by close to 30%, heart failure 30%, and mortality of 30%. So ideal blood pressure is 110/70. Targets of blood pressure are moving to 120/80 in high-risk people, provided you're not too dizzy. And look how you measure blood pressure. You're sitting relaxed. No one's talking to you. You should never measure a blood pressure in front of me. I bring up blood pressure. You want to have your feet on the ground. You want your back supported. You want your heart at heart level. You want the cuff with the tube pointing towards the machine. And make sure you do this well, right, and repetitively. And if you want, you say, well, my blood pressure is always the same. I argue that I measure my blood pressure about 2 to 3 times a week on a regular basis. I do tend to measure it more on the weekend, though, and it maybe not the ideal time, but certainly a time when I'm more relaxed. And I think multiple readings and at least a series of 3 readings. Do we have the slide about if you don't measure it properly? Did we have that slide there, Rad, in there at all or not?
Oh no, but I know what you're talking about. Actually, the biggest one by far, and correct me if I'm wrong, is speaking. And actually the
Coffee.
cuff, wearing
Speaking.
something underneath the cuff, and coffee, and having your bladder full. But there was a range. Remember, the American Cardiology College of Cardiology put a range of how little
If it's
and how
small,
high.
too
Yeah.
big, and so there's a way of doing this. And to me, there's 3 ways of measuring blood pressure. The one you measure at home, the one we measure in clinic, and the 24-hour blood pressure machine. They all complement yourself. And I think it's really important to look at that to get a really good picture of your blood pressure target. I'm really amazed at how few people really pay attention to their blood pressure. I think it's a good hanging, easy fruit of living healthier. So I think it's a wonderful slide. Take a picture of that and make sure you measure your blood pressure often, many times. And don't panic if the blood pressure goes to 260. That's okay. I mean, it goes up, now. It's that blood pressure variation. I mean, it's a totality of information. I'm totally amazed how people just panic all the time. My blood pressure has been at 260. I haven't gone to any emergency room. When I weight lift, my blood pressure goes to that high value. So just relax, measure lots of readings and things of that nature, and an important slide. Tell us more.
Let me take us back to where we were. There you go.
Yeah, so actually we can move on
Skip this one.
to
Yep, go ahead.
Well,
Yeah,
go back one more. Hold on. We have the medical stuff. This is kind of important. So, you want the best of modern day medicine. And John's ejection fraction is 51%. Normal ejection fraction is about 55%. So he's had some small degree of damage. He can go on a stress test and can do an estimated workload at 10.2 METs. That's your horsepower. One MET is your basic metabolic rate. You need about 5 to 6 METs to function, do your shopping, work around the house. Anything over 12 METs or so is very good. 10 METs is basically good horsepower. Remember, Lauren, Rad, if we put you to bed rest for 2 weeks, you lose 25% of your horsepower in 2 weeks. A young, healthy person. You take an older, sicker patient. Let's say you're doing 6 METs of work on the best of times. You now have a pneumonia. You got COVID. You fell and broke a bone. You're going to go from 6 METs to 4 METs in 2 weeks if you're not doing anything, and you can't go home. you have to go to convalescence, maybe to a nursing home. So that's important. And so I think it's important that's why we measure a lot of stress testing. The stress technologists like to go to heart rate. I like to go how your horsepower is. So John's horsepower is pretty good. How old are you, John?
Well, I'm happy with that.
Yeah. How old are you now?
I am 75. My birthday was in November.
Okay. So that's important. John's 75, so he has an injury, a pneumonia or an illness. He's going to lose some reserve, but he's still going to be able probably to go home because he has enough reserve in him. Because he has that he can do those 6 Mets if he goes from 10 to 8 Mets after an illness or so. So that's important to look at that. And so that's why we do the test to find out what's wrong. And we do the test to monitor. Next slide, please. Tell us more.
Yeah, so now we'll be moving on to how John started seeing Dr. Kunu. And on the next slide, we'll learn a bit more about his heart attack. So it occurred when he was 62 years old, after he retired. But yeah, interesting fact, John has been an avid traveler in Ontario and the Maritimes, and for 5 years, John pulled a 32-feet trailer to the Maritimes. So that's pretty impressive. But yeah, that's why he was driving around Lake Ontario in freezing temperatures, looking for a pull trailer for their truck. But then when he got home, he felt a pain that felt like a heavy shot put to the chest, and told his wife, and initially didn't think much of it, and thought it could be due to freezing weather. But yeah, and then after that, he saw Dr. Curnew on February 16th in 2011, and got his bypass surgery after that. Yeah, do you mind kind of elaborating a bit more on your experience?
Okay. I went to the hospital that, after feeling the shot put, went to the hospital, and I had the test, and I was at the Juravinski Hospital. And then Dr. Curnew, when I was at the hospital, Dr. Curnew came in and he introduced himself, and I always remember what he said. He basically said, "I understand you're a math teacher." And I said, "Yes." And he says, "Well, I'll put it this way. We'll have a meeting in 1 year from now, and the chance of you being there is 1 in 4. Do you want to have the operation?" That's when I found out about the blockages in my heart. I had no idea. I had no idea about the blockage in my heart. 2 of the blockages, actually, I had 3 at the time. 2 of them were serious. And it was Dr. Lee. He was actually on loan from Toronto. And he was one of the few doctors that had well, put it this way. When I woke up, Dr. Lee said that I did not have 3, I had 5, but I had 5 to bypass. And he said I didn't want to go in again, so I fixed him for you. And I was very lucky because he was one of the doctors that was actually on loan from Toronto who had done 5 bypasses, whereas a lot of the heart surgeons in Hamilton had not done that. So I was very, very lucky. I was very glad that Dr. Curnew put it that way. Do I want to have the operation? Because I'm a very stressful person. And if he just told me you have 3 bad blockages, I'd probably think a lot different. But putting in the case of doing it from a math point of view, I can understand. And yeah, I agreed to have the operation.
So it's kind of interesting. This disease took 61 years to develop. And what happened is a heart attack is like a volcano erupting. I guess it's like meeting a politician, and just just everything exploding. And the problem is that predicting who's going to have a heart attack and when is a challenge. And we know that for stable disease, doing an operation doesn't really prevent a heart attack. But once a plaque is ruptured, there are lots of things in. And he's actually showing us a picture, and you probably can't see this. He's one of these guys that has detailed records. So he actually has showing that his LAD is 75 blocked, his diagonal degrees has 60% blockage, RCA has a proximal 60%, 99% distal lesion, circumflex 60%. That's Dr. Talk. For you, you're up Schitt's Creek. You have 3 blocked arteries, and we need to, and you've had a plaque rupture. You can have, I have 3 blocked arteries, but I don't need I don't need an operation at this point in time. I need good medicines, and I need to try to prevent. And you're right. You're saying is that the Hunger Game is that predicting the future can't tell you for sure what's going to happen next, but you can actually stack the odds on your favor. So we're going to show you some odds and things of that nature. Wouldn't it be nice if we can actually predict the heart attack the day before your operation, or before your plaque rupture? That would be great. We can't do that. We're now looking at plaque composition, different modalities, but we can look at severity of disease. Severity of disease does not tell you if you're going to have a heart attack or not. We know that the more the burden of disease, the more blockage you have, the more diffuse nature, the more likely you have a plaque that's going to rupture at this point in time. But we can't predict which plaque is going to rupture and when. Once it's done, you call 911, you get to the hospital. So I like to keep saying is that I admire John. He's going to show you his binder and things of that nature. And what happens next? Tell us more.
Yeah, just to kind of also touch on that, all of what you guys said is that, yeah, with the odds, talking about the odds stacking in your favor, and as well as how Dr. Kanu shared that experience, shared this information with you. Actually, after the surgery, you found out you had 5 blockages instead of just like needing 2 couple stents like you and your wife initially expected. So yeah, kind of again puts everything into perspective. Yeah, so John's goal is to be the longest surviving patient of Dr. Kernu's. And yeah, John has always been an active person, but ever since his heart attack, he has been super careful about monitoring his health and minimizing his risk factors. We'll get into how he does that and how he takes care of his health shortly, but wanted to again just emphasize how Dr. Kerner's advice and guidance has kept him alive for 14 years, and he has a good life. And that's a quote from John himself.
And remember, a bypass doesn't fix the underlying problem. It is a temporizing solution. And if we're not prepared to make the steps to fix the foundation, then you're in trouble. And John has fixed his foundation.
Yeah. All right, let's start talking about what John has done to improve his health and work on his risk factors. So here are all the motivations and the reasons why he cares about his health so much. John was actually 200 pounds before his operation, but now has successfully reduced his weight to 160 pounds. I guess the question is, were you always so proactive, or did you become more proactive after the heart attack or getting older? And why do you think it's so important to be proactive about your health?
I would say that it's necessary to lose weight and lose weight because I just continued being active. I do a lot of walking. I was dancing a lot because my wife plays the fiddle, and we used to go dancing every week. But that's sort of curtailed since the COVID. But I go walking, and by the way, during the winter, I'll go walking at Lime Ridge Mall. To go around Lime Ridge Mall 3 times is 5,500 steps for me, which is half the 10,000 steps Dr. Kernu insists everybody does every day. So, and that's what I do. In good weather, I go. Sometimes I go and watch cars go by in Upper James, and because I like looking at cars, or I just grab a coffee and walk.
Nice. Yeah, we also know that John has cut down a lot on red meats and carbohydrates, and even successfully lowered his LDLs to less than 0.5. We talked about 1 earlier, but yeah, so those are all the different ways you've been losing weight. do you kind of prefer walking or watching your diet? Which one comes a bit easier to you, maybe?
Walking. There's no
Yeah,
no
for
doubt about it,
sure.
because I am diabetic, and sometimes, yes, you go over the top and you have a bit more sugar than you should. But no, walking also is very peaceful because it gives you time to think.
Mm-hmm. Yeah, for sure. Um, yeah, and then
Go ahead,
maybe
keep going.
a bit more about the knee pain as well. Has your knee pain or any other conditions ever made it difficult to maintain your health or do these
No,
exercises like walking?
every since I had the I've had both my knees done,
Mhm.
and everything has worked fine. You just got to keep active. That's all. I do not have
Mhm.
any knee pain anymore. And
Mhm.
actually, don't tell the surgeon, but I can actually be on my knees and it doesn't bother me. And I don't have any problem getting up. So
Mhm.
the knee surgery went fantastic. I'm very lucky, and I'm not in any pain because of my knees.
It's kind of interesting. The biggest predictors of getting knee or hip operations getting older and how much you weigh are the two biggest predictors. And obviously, injury plays a factor. And what I didn't realize is that hip surgery is usually more successful than knee surgery. And to me, one way to control pain is that through regular exercise, is that you strengthen all the ligaments. And I've been struggling with hip and tendonitis for about 6 months now, and I worked very hard at trying to what we call sort of load the joint, work through different exercises and stuff. And I just encourage, and the place I go swimming, there's this guy that walks in the pool with his arthritis. He walks in the pool for half an hour to an hour. I do a little swimming and we chat a little bit, and I do all sorts of activities. I just want to encourage people is that um, activity, if you can find something you enjoy, it is very peaceful. It really is, to me, it's the world's best antidepressant, the best way to treat pain. You got to keep moving. And if you're not prepared to keep moving, I'm worried about you're going to end up in a nursing home before your time. So that's really important. Thank you for doing that. Um, um, and there's appreciation of life and feeling gratitude is really important as well. And yes, you can prevent a heart attack. Maybe you can't prevent it forever, but you can put big dents in it. So tell us more.
All right. Yeah, we can move on to the next slide,
Yep.
and Morgan will take it from here.
Yep. So this slide is basically just a screenshot from John's Freestyle Libre device, so his continuous glucose monitor. And this is actually from today, just after dinner. And you can see it's kind of really gotten lower because this was after he took his medication. But John, do you want to elaborate on how you kind of go about managing your diabetes?
Well, actually, what I'm concerned about, if you look at the slide, is where it peaks. And um, that's what I'm concerned about it. But I'm trying to I try to keep it between 4 and 10. And I find the best thing to do is you got to keep your medications, and you got to eat in moderation, eat sugar in moderation, because you're going to have some. And I love donuts, but you got to keep it down in moderation. That's all. And you exercise. And again, you got to take your pills. I'm very lucky. I take very, very little insulin. I'm only taking 16 units of insulin. So yep, I just hope the best.
So the Libre device is a funded program in Ontario for people at the age of 65 or on social assistance, or people in the age of 25 who are on insulin therapy. So I have to purchase my Libre device. It costs $90 for every 2 weeks. I do it periodically. So I look at myself. If I had that donut, um, my blood sugar goes shooting up, and my pancreas is wearing out. And I made steps to put my diabetes into remission. Now, definition of type 2 diabetes is two hemoglobin A1Cs consecutive over 6.5. I had one at 6.6, and usually mine hovers around 5.8, 5 points, I think 5.6, 5.7. And so I never had a second one, and I really worked hard at getting my weight down and losing 25 pounds. I'm up another 5 pounds. I'm down 25 pounds. I'm down 20 pounds. It's really a lot of hard work, and it's I'm continuously hungry. You can try intermittent eating, try different foods. Uh, I just learned that instant oats bring up your blood sugar. You need to have rolled oats and add that protein to that, and you can actually play
Yeah.
around with foods that are
Yeah,
important.
Yeah, oats. By the way, I think still the most important thing is that if you're diabetic, you cannot drive below 5. And I lost 2 friends in Hamilton, two students who I taught. And they were killed. They were killed by somebody who did not manage their diabetes. As I said, two good students.
So if you have type 2 diabetes, every year you're 40% more likely to unfortunately have a cardiovascular event, more dementia, more Alzheimer's disease, more atrial fibrillation, more kidney failure, more blindness, more cancers. And so we have to work hard at controlling. To me, I found the joy of have you ever tried this at all, John, about time restricted eating? I find I'm trying to convert my eating habits, but I find that I'm best is that if I stop eating around 10, 11, 12, and I don't eat again till sometime in the afternoon, just have coffee, a little bit of milk, and I find more energized.
Well, I have to be concerned at nighttime because ideally I should take protein before going to sleep. Otherwise, I will probably go low.
So learning yourself and
You
learning
learn about yourself.
Yeah. If you have diabetes, you got to go for your eye checks. You got to look for proteinuria. Lots of things you need to look for that there. So you have to look after that. Thank you. Next slide, please. What else next? And go ahead.
Go ahead. Yeah, just wanted to share some of the cocktail of medications that are important after MI. You can comment on this, Dr. Kearney. Any thoughts on this?
Well, so aspirin has been a good friend for a long time. At one time, we used to use aspirin to prevent a heart attack, but we found that aspirin probably decreases the risk of a heart attack by 10 to 15% at best, but increases bleeding risk by 40%. And so if you never had a heart attack or stroke, we no longer use aspirin to prevent a heart attack. But once you had a heart attack or stroke, aspirin's a good friend. If you go for a stent or you've just had a heart attack, the plaque's unstable, we often use 2 antiplatelet agents. One is aspirin, one may be clopidogrel, ticagrelor. But we're also learning that clopidogrel is probably better than aspirin and safer than aspirin. So there are many people with heart disease. We can talk about whether or not aspirin should be their mainstay of blood, an antiplatelet or a blood thinner, or clopidogrel. And so using clopidogrel alone may be something to think about. At one time, we used to use beta blockers as a standard approach after people who've had a heart attack because it decreases repeat heart attacks by 25%. What our modern day therapies are limiting heart damage, and if your heart muscle is good and strong, you may not need to be on a beta blocker long term anymore. The godsend of preventive medications is getting that LDL cholesterol, that 3-1-1 rule, keeping LDL cholesterol less than 1. So being on a good plant-based food diet rich in fiber, you can decide if you want to incorporate meat. I'm trying to get as much fiber, much beans as I possibly can. And I eat fish, but I try not to eat red meat for a number of reasons. One is the environment, one is animals, and one is health. And I think the combination of a high dose statin therapy, Lipitor, atorvastatin, 80 milligrams, Crestor, or rosuvastatin, 40 milligrams, along with 10 milligrams of ezetimibe, is the cornerstone of treatment to prevent your repeat heart attack. If you have a high triglycerides, we can use Vascepa. Now, controlling blood pressure is important. ACE inhibition, ARB therapy is of value in patients who have congestive heart failure, diabetes, or have high blood pressure. So getting the right cocktail of medications. It's like, the Toronto Maple Leafs are trying to get the right winning formula to win a Stanley Cup. There is a winning formula for heart disease prevention, and that needs to be worked with your physician. And one thing that's really important, and I really find this really challenging, is that a lot of people are making changes that are good. We appreciate that, but keeping track of what you're taking, and we're talking about this, is to this day is that, you know, always bring your pill with you, bring the right medications, right time, not an old list statements like same as last time is fraught, whatever. Sometimes we don't need to check too much. Sometimes we need to dive down really deep and look at every minor detail in that circumstance. And John, what are you going to show us there?
No, you can. Yeah.
We can see it well, by the way. Just made it a little bit bigger for folks. Go ahead.
So this is his medication list.
Yep.
Yeah.
And you know,
What it shows what I take, when I take it, and how much.
and I love the pill bottles too. Who prescribes what? How many refills that you have? It's you know, getting it right is really really challenging. So here's John's medication list. And you know, some people will get their medications wrong. The lists are outdated. Some people are really good at that. I want to feel confident every time I see you. I know exactly what you're taking. I'm trying to apply, you know, a plane glider, and we have our checklist. This is an important checklist, and so I prefer the pills. I know John keeps track of these things. I can trust what he gives me. I have so many people who pull out a list that was dusted off in 1924, and so really important to really get this right all the time.
I just like to add is that my wife and I travel a lot, and a lot of the time, you know, if you have to go see a doctor, you're not at home, you have to go to a doctor, you have to go clean out a hospital. The most important thing is they always ask you what medications you're on. I just take out my list, I carry it with me, take out my list, here you are. And doctors are much more happy when they have a list of what you're taking.
Or the actual pills. But you need to be looking at that. So one of the interesting things, we have a target heart rate of 60 beats per minute. That's basically in people who have a damaged heart. We want to keep the heartbeat around 60 beats per minute because we can make the heart stronger. We have pillars of therapy to make that a difference. You can look at insulin controls blood sugar, but doesn't prevent a heart attack. Metformin stabilizes the diabetes. Genumet stabilizes. Jardiance, very interesting, is that so, you know, metformin may show a slight prolongation of cardiovascular events. The Januvia doesn't prevent a heart attack. Jardiance is a category of medications called SGLT2 receptor antagonists. For Zika is one example. Of another one as well is that these medications decrease end-stage kidney failure by 40%, decrease hospitalization for congestive heart failure by 20%, and associated with a 5-pound weight reduction. Amlodipine is a calcium blocker. It lowers blood pressure. Glycoside is old-fashioned sulfonylurea that helps stabilize the blood sugar. Beta blockers are basically in people who have angina, atrial fibrillation, and congestive heart failure. Ezetimibe and rosuvastatin, man, that's a powerful combination. Ezetimibe works in the intestine, rosuvastatin works in the liver, and I take these. And if you're B12 deficient, I need to take B12, and it's more common as you age, and people who have diabetes are on metformin. Aspirin is been around for a long time, and we can talk, John, if we want to switch her from aspirin to clopidogrel in the future or not. That's sort of a little gravy there, and having nitro spray available to you is a good idea. And John has his plan if he gets blood sugar low too low, and having his glucose. So, you know, is that getting this right is important, and he's going to just show us right here. He's just carrying that with him right now. He has his little kit, and we'll just show that.
That's the spray.
He has his nitro spray. One of the things is nitro spray does get outdated, so that's something to be aware of. Many medications don't get outdated, but nitro spray is one of them.
It probably needs replacing.
And here's is that he has this little sugar if he needs to as well. That's fantastic. So I'm hoping everybody takes this to heart. If you walk away with a clear message, is that leading cause of the preventable errors is getting medications right. There's also something called sick day medications. When you're sick, what medications to stop and put on hold. We can talk about that at a later date, but really understanding what you're taking, important. Have people around you know what you're doing. Have a good pharmacist. The only bad thing about pharmacists, they don't have access to your medical records. They don't know exactly all the finer details. So they can only tell you certain things. They can't tell you the finer details. One of the things that our Ontario government has done is that they're closing bike lanes. They're dealing with congestion and traffic and things, but I would encourage more bike lanes and one electronic medical record for all of Ontario that people have access to. That would be, we're talking about a healthcare crisis. We are in crisis. One thing is really putting together a national electronic medical record would be a huge plus. And I think in the scheme of things would be cost savings, but no one's asking me what to do. But I'll just thought I'd give my 2 cents in there. I can tell you a few other things too as well. But knowing what you're taking is so important. And I'm very confident I know what this guy's taking.
Thank you.
Yeah, so I think next we're just gonna go back a little bit and talk about LP little a. So Rad, if you want to take this.
Yeah, of course. I was gonna ask John. John, have you heard of LP-A at all?
No, I haven't.
Yeah. Well, I was just asking Lauren as well, just to see how many people know about it. So LP-A is LDL's twin sister. Very similar, just more sticky to the arterial wall, essentially. And the recommendations right now is to have everybody test this once. And you can see some of the values. The right one's nanomoles per liter Canadian values, the left milligrams per deciliter American values. So anything above 100 is more risk. Now, how much, Dr. Kearney, you mentioned the figure that's more memorable, 2 to 4-fold, 2 to 3-fold increased risk once you have high LP(a). And in Canada, 1 in 5 have high LP(a). In the African continent, it can be, I think, 1 in 3. South Asians, 1 in 4. So it's genetically determined. Ethnic backgrounds play a role in it as well. And unfortunately, we don't have medications for people with highest LP(a) levels. I saw one in the clinic around the 1,000 range. So maybe those people will be benefiting from any medication in the future. But for right now, it's all about keeping LDL, actually right here, keeping it less than 1. We have it here. John, less than 0.5. Sometimes it's undetectable with a combination of lifestyle medications and a little bit of luck to have the receptors to respond nicely.
I think it's a lot.
Yeah. So, but I think yours was not high, if I remember correctly. It was less than 10. So you're in the green zone when it comes to that
So
that metric.
just backtrack to LPA. The reason John doesn't know anything about it because his was 10. So his
Yeah.
is very low. I wish I had his. Mine is over 200. So so if you see that slide there, we call relative risk there. I'm not sure you can put a cursor there
Yeah.
on that. You can see that number of 100, you're at 1, and you can see as you go up, if you get close to 200, you're 1.5. Around 300, you're 2, and you're above 350, you're getting close to 3 to 4 range. So you can see it can double to 2 to 4, between 1.5 to 3 to 4 times risk in some individuals. So it should be measured once in a lifetime. It should be measured when you're healthy or not sick, because if you get acutely ill, it will be falsely elevated. So I have a high value. My one younger son has another, well, actually younger. Both my sons are younger, thank God. I don't know how I can have an older son, but my second son had a high value, but he had an acute illness during that time. So we're going to remeasure that one. So I'm stuck with that genetic factor. And you may have that as well or not. So just have that measured once in a lifetime. John, yours is very low. You don't need to worry about that.
Yeah. Great.
And I like if we go to some of the other slides here, is that all of us can do is modify our lipid parameters. Can you show us the next slide if that's okay?
This one?
Sure, that's a good one to actually backtrack. Let's look at the slide before then. This actually talks about the data of a linear relationship. These are all the clinical trials. Hundreds of thousands of people. In blue are something called the Mendelian randomization data sets. Those are people with genetic cholesterols. You can see in red is the randomized data set. In gray is the observational data, and they're all very linear. And the reason why genetic studies are more important, these are lifetime risks. So if you have a genetic high cholesterol, your lifetime risk is a problematic. You're born with an LDL cholesterol around 1, it gradually rises, and we accept that cholesterol around 5 as being average or normal. Normal leads to too many heart attacks or strokes. So if you want to have a heart attack or stroke, be normal. And one of the things we're talking about is lifetime risk that's evolved right now. And some thinking is keeping LDL cholesterol less than 1.8 to over a lifetime, maybe something we need to be thinking about starting younger people on cholesterol medications. Personally, my dad had a bypass at 50 years of age. I'm 65. I have some blockage formation. I've taken my cholesterol seriously. I wish I started my cholesterol pill when I was 15 in retrospect, or starting at the age of 20, I think would be very ideal. If you have certain genetic problems, you need to start earlier in life. And so that's knowing your family tree and your family history about this. So next slide, please. The other interesting caveat is we have, if you can just backtrack to the next slide about the 311 rule, go right here. I really like this rule. You have 911, that's what John had to do to get his bypass operation. He was fine one day, next day he has 3-vesicle coronary disease. This is a lifetime disease that's developed. And getting your cholesterol total at 3, LDL lousy less than 1, HDL healthy greater than 1, and getting your triglycerides, which are more amenable to lifestyle changes less than 1, are the ideal parameters. You can see, John, this is fantastic. They're better than mine. I wish mine were as good as yours. And some people will say we should cut back. No, this is what you need to do. This is and it's interesting. I see so many people that can a cholesterol be too low? Only for politicians. Is that but basically this is fantastic, and this is something I wish I can see more of. So John, I'm really proud of those values. So you're working hard with medications and lifestyle changes. Let's keep it here. Any tips you want to provide to that you're doing to keep yourself at these values?
I would say I want to live. I have a great life. I want to live as long as I can. I want to stay healthy. I would say that for someone with a heart, believe in your cardiologist. I have a great cardiologist, Dr. Curnew. Follow his advice. Keep prescriptions up to date. Carry a list with you. And to keep myself busy, I walk a lot. Walking is the exercise and gives me time to think. Mentally, I do Sudokus and play bridge. And I also read. My wife and I travel a lot, and we travel right now. We're traveling about 4 months a year, hopefully. And I think one of the most important things is to keep stress levels down to a minimum. Realize what you can do, and realize what you can't do. But I think it's important to keep your stress level down and just live your life. Life is short. Just live it and enjoy life as much as you can.
Well said.
Right. All right. Wanted to talk about vaccines a little bit. John, you looking at these slides, COVID and flu, pneumonia vaccines, RSV, which one of them have you had in your lifetime or perhaps recently?
Let me see. First 2. I've had the first 2. I have not done 3 and 4. I'm thinking about number 4. Dr. Curnew has suggested it, but I haven't got around to doing it yet.
Yeah, so you can see these are the big 4. There's also
Oh.
some of the other ones at the bottom. Yeah,
I've
go
had
ahead. Go
shingles
ahead.
shot,
Yeah,
and my tetanus is up to date.
good.
And I don't know if tetanus and diphtheria is the same shot. I don't know, but I know I'm a tetanus shot.
I think
Is
that every 10 years is a booster for those 2, for tetanus and diphtheria. Yeah. Dr. Kearney, you have had the pneumococcal shot.
Yeah, so basically is that these are some of these are covered drugs. So none of these drugs are so-called free. They're paying out of your tax dollars. And so COVID's an interesting disease, and we'll talk about that in a sec right now, is that COVID, as you know, caused a lot of carnage, a lot of political unrest, and it still does to this day. And I'm amazed that we have technology that can be developed a vaccine. COVID is the most tested vaccine known to humankind ever, period. And basically, what I'm doing myself is that I'm trying to get a COVID shot every 6 months. And one of the things I learned about vaccines is that, for instance, like measles is a disease that's very preventable because measles has a longer incubation period. So if you're exposed to measles, it has, I think, a 1 in 1,000 risk that can kill you. It's more susceptible in younger and older people. And this is a very curable disease. And if you've been exposed to the measles vaccine, your immune system is ready to fight, and it will actually prevent illness. Where in COVID, because the incubation period is very short, somewhere for about 4 or 5 days to maybe 10 days or so, your body does not have a chance to actually prevent the infection. So we were wrong initially, and we didn't know that back then, is that so the COVID vaccine actually prevents severity of disease. It's like a seatbelt, doesn't prevent the car crash, decreases severity. The maximum effectiveness of the vaccine is in the first few months of therapy. So, John mentioned he travels. I try to travel too as well. I try to get a COVID vaccine every 6 months at this point in time. And I try to time it 2 weeks before I go on a major trip. And we'll talk about this, is that COVID is a year-long disease. In fact, it peaks last year, peaked in the summer more than the winter time. The flu peaks in the winter time. We have very good data that the influenza and both COVID damage vessels. And thank you for sharing some of these information over here. You can see that you can see when COVID peak, or you can see when flu peaks, it usually peaks from COVID. This is actually
Just wanted to
showing.
show this, Dr. Green, since you mentioned.
Yeah.
So for COVID, it's been interesting. The difference with flu is usually you see in the fall and the winter in the northern hemisphere where we live. COVID is a seasonal virus, and this is an example for the past year. In the summertime, July time, you can see the peaks are higher. This is U.S. data. You don't have this in Canada, at least I'm not aware of. But anyhow, you can see it's the year all around. You have multiple peaks. Whereas with the flu, right now we're in an all-time 15-year high, and you can see something I was going to in the middle diagram where it says March 2025 in the blue section. That's influenza US data right now, which is on the rise. So February, March right now says people still haven't gotten the flu shot. Still not too late, right? Because there's this notion that get it by October, which is probably not the worst idea for people to get something, but then the immune system slows down over time. Viruses change 3 months, 4 months or so, and some people need a booster as well.
So we're still learning about COVID right now. And right now is that I think a lot of if you go back to that initial slide about when it peaks, it really probably depends on when the virus mutates. And we're still learning about this. So is it, the thinking was going to be more a respiratory virus in the winter months, but so far hasn't panned out, and the final picture is still evolving right now. Show us some more slides over there.
You mentioned something, Dr. Green?
Oh, show us some more slides there, which you got there.
Oh yeah, sure. Let's move on to a little bit of family talk. Morgan, lead the way.
Well, actually, no. Go back to go back to the vaccines a little bit over here. Go back to the
Big Four.
Big Four.
Yeah.
So one of the things is that you can choose to be sick, or you can choose to have protection. So these are something everybody should take a screenshot. Prevnar 6, Prevnar 20 right now is a funded vaccine. RSV is funded for people in nursing homes. So right now the vaccine is around $300. It probably lasts about 2 years or so. And it's something that you can prevent you from going to the nursing home. Shingles is a terrible disease. It can be for some people. It can cause intractable pain. If I remember correctly, about 25% of us will have shingles at some point in time. if you get true tetanus, you will die. You don't survive from tetanus. So that's why immunization is so important if you're at risk. So think about these vaccines. Vaccines has a long track record. We know about polio and measles and how those diseases have been really uh, eliminated if you're properly vaccinated. So some diseases we can actually eliminate, some diseases we can't vaccinate. We don't have a vaccine for HIV, and we're learning a lot. So don't be so polarized. Just use good science and listen to people who know what they're talking about. Unfortunately, I don't know how you find out your information. I'm lucky I listen to a lot of different so-called experts to help that opinion. So I'll share what I know and I'll tell you what I don't know. Tell us more. And John just showed me over here, he had his tetanus vaccine. He has a little piece of paper here. He keeps track of everything. Thank you.
Yeah, just to talk about, since we were talking about the flu and pneumonia, we put this list together of what's killing Canadians in 2023. You can see cancer is still at the top. I think heart disease used to be number one, and you see there's quite a bit of difference. Um, and then accidents, and this is in everybody's, it's all ages. That the accident number will still be a little bit less for people above the age of 65, but it's something we don't talk about, right? Deaths from accidents, going on a ski trip, not being careful, and things of that nature. So accidents, diabetes, COVID and flu risk factors, short term and perhaps long term for cardiovascular disease. And some of the other ones, we're not going to make this grim, but Dr. Kern, you mentioned what's the life expectancy once you hit 65, so it's about 20 years. So make of that what you will, good or bad, right? If you want to think like John, you want to make the best of all the time you have left and stack the odds in your favor, as you said, right?
Let's pause here for a second. So when I started, heart disease number one. Now you can put stroke, cerebrovascular disease, and heart disease together. So that's 5713. That's 70,000 lives in 2023. You can see as you get older, your immune system worsens, and basically immunotherapy, how modern immune systems become important for cancer at this point in time. Look at COVID. It caused in 2023 8,000 people to die. Influenza, pneumonia is a problem. And you can look flu and pneumonia at 6,000. More people are likely to die from COVID than they are from pneumonia at this point in time. And yet people are afraid to get vaccinated. Younger people, it's not unreasonable to get vaccinated once a year or so for the flu and influenza. The reasons to also vaccinate yourself is to prevent damage, concussions to your brain. We learn that banging your head causes brain injury. Uh, these infections cause damage to your blood vessels and to your organ system. So these are actually kind of important. So I'm really paying attention to this, and so as we get older, we're thinking about how much time do we have left. Look at this. If you make it to 65, do you get your CPP at 60? Do you get it 65 or you wait to 70? These are things, decisions people have to make. So if you're at 65 right now, you're expected to make it to around 85 years of age. That's the time frame. There's always lots of exceptions. We're learning to live longer and better. Properly vaccination makes a difference. Proper prevention makes a difference. But I'm right now going to be 66 soon, and how do I want to spend the last 20 years of my life at this point in time? I hopefully that we'll be around to a lot longer, but that's the average is the average, and we'll see what happens. But look at these numbers here. These are real numbers, and if you smoke, if you drink, if you're overweight, you don't know your blood pressure, you don't know your cholesterol, you're not properly immunized. If you have underlying atrial fibrillation, you have a family history of cancer, um, you know, um, um, I've known so many people, their parents had colon cancer, they never went for a screening colonoscopy. Unfortunately, they have colon cancer now and things of that nature. So there's a lot of things. Cervical cancer is a disease of a virus that you can be vaccinated against at this point in time. We're going to learn the impact that what COVID does long term. I'm scared of COVID. I don't think it's a a benign process. It's not as severe as before, but what does it do to your brain, to your pancreas, to potential for cancer in the future, long COVID, heart disease? We're learning. So to me, the best way to get COVID is not to get it. So we'll talk about that. How to think about what to do next. So this is an important slide. And thank you for sharing. This is the more recent data, 2023, constantly updated. Thank you for sharing that.
Of course. Now let's talk about family and some of the good stuff. Moving from the grim and into the joy.
Okay, yeah, so definitely a different turn. But yeah, so John lives happily with his wife, and he has 5 grandkids and 1 great-grandchild, which is amazing. He doesn't really live with his kids, but he does get to see them, which he really appreciates. John, I know you were telling me about how a healthy married man is much better off than single. Do you want to talk more about that?
I mean that because I have a wonderful wife. She takes care of me, and it's our second marriage. We married for 26 years, and I think my wife is fantastic. And we go, we agree on most things. We do have our arguments, very small. They're, very not very often, but they occur. But we have basically the same outlook and the same things that, as I said, we're traveling because we don't know how much time we have. We're traveling in Canada, by the way. We travel to the Maritimes, and my wife likes the tides. And anyway, but I think the most important thing is I have a fantastic wife. And yeah, we have grandkids. She has 5 grandkids as well. And we see them when we can.
Nice.
Yeah, and also in terms of health and exercise groups, John, have you ever taken part of any exercise groups? I know you told me about the Marston Church seminars that you attended in the past.
Not really. I would when the weather gets warmer, and because I'm here all summer, I would like to get into an exercise group. It's just fun. It's just fun doing exercise with people.
Next slide. Yeah, this is just a slide showing how just muscle really declines with age. So we can just really see how exercise is so important. So on the left panel, we see that on the very left, it's a 24-year-old male. And you can see by like the dark area that they have a lot of muscle, and that really declines, as you can see.
That's a thigh muscle, right?
Yes, that's correct. That's the thymus.
Look at your thigh muscle. You can see the bone there. You can see lots of muscles in a 24. These are actually triathlon runner. So these are elite people. So look at a triathlon person in their 20s, and look at a triathlon run. If you can show, maybe put a little arrow to that, if that's okay. And you can see what happens to a average 66-year-old sedentary person. You can see that muscle is being replaced next to that with a lot of fat, and you can lose. Look how much muscle that you can lose. And and on your far right, are these the triathlon ones I gave you? These are normal people.
These are normal, but the left one is very similar. Essentially, where I put a similar one where at age of 66. A very similar MRI. We can see the more activity, 130 minutes versus 22 minutes. You can see the muscle mass that's kept in the right one compared to the central one.
Yeah, sorry, I was just looking at one of a triathlete of a 77-year-old triathlete person compared to a 20-year-old. So this is actually what happens to, I apologize, these are what happens to normal people. And what type of muscle did you want to have at this point in time? You can see, so one person here, you can see at 66 is doing 3,000 steps versus 12,000 steps and physical activity in a muscle biopsy. And maybe you can explain that graph on our right there. What does that tell us there, Brad?
Well, yeah, what I was gonna So what you're looking at on the y-axis, I know, John, you're a math guy, you appreciate this. On the y-axis, we have the muscle mass levels. Doesn't have the units, but and then on the x-axis, you have the age. What I want to show is that there's a precipitous decline at 70, 75. We can see the slope, right? The speed of the decline gets more severe at those ages. Now, lots of different reasons for that. Illness, falls that we're going to mention, that makes people sedentary, and you lose a lot of muscle mass very quickly. Hospital visits, losing muscle mass very quickly. So it's all about trying to play the long game. How long you can keep this at a decent level with walking, with resistance training, whatever you can do, body squats, and throw the kitchen sink at it essentially.
So you can see you're building muscle to your 20s and 30s, and then it starts to decay, and then it accelerates. And you can see to prevent that deceleration is that you have to lift weights, you have to do aerobic activity, and you have to have adequate protein. The protein's the easy part. The lifting weights is something that most of our generation didn't grow up with, and that's something that I've tried to change as I get older. I feel a huge difference. Do you feel a big difference in your muscle strength compared to when you were in your 20s?
Oh yeah. Oh, definitely. I just look at that slide and I think, geez, I'm going to keep walking, exercise as much as I can, rather than just sit down and watch TV all day. No. You got to get up. You got to get, just looking at that slide, you've got to get up and keep moving.
And I'm going to also encourage you to lift some weights and do some resistance training as well, from bands, push-ups, sit-ups, squats, and lifting some heavy weights. Thank you for sharing that. Next slide.
Yeah, and as you may know, about 1 in 3 Canadians who are over 65 will have a fall each year, and these can really be kind of like a leading cause of death in seniors. So it's really great to have a mix of both like strength training and aerobic activity, and also some like maintaining your having good balance. So it's great that John is really active with his steps.
Well, I think this balance training is kind of interesting. One of the things is that I'm having trouble with my balance as I get older. Brad, do we want to pause and do a balance exercise at all?
Sure, actually, good thing you brought this up. Anyone who's listening, and even in your clinic, one thing it's good to do is a 10-second one leg stand. So if you just stand up behind a desk, hold on to a chair, and just stand on one leg and hold the other knee a little bit higher, perpendicular to the floor, and see how long you can last. It's not that difficult, but if you want to make it challenging, you can close your eyes. Shall we try that right now, or we can try later?
We're doing it now.
All right, let's do it. Let me put the cameras on here for everyone. All right.
I'm doing it with my eyes open so far.
Well, I think actually it can be quite difficult if you completely close your eyes. And actually, there's a test video I was listening to where young people couldn't do this. So if you can do this, it's quite good. So more than 10 seconds, you have good balance.
Okay. Now I'm going to try. I have a good leg and a bad leg. I'm going to switch now.
Yep.
And so I find that I'm left-handed and left-footed. So when I try to keep my right foot down, I find that harder. Yeah.
Same with me.
Now try to close your
I'm
eyes and
left-handed
see what
too.
the difference is.
I can't. See, I got to work on it.
Yeah.
I'm going to work on that one. So I'm going to close my eyes. So I can't do that now, but it's something.
It's difficult. Yeah, I'm trying it.
It's way more difficult than I expected.
And you close your eyes. Yep.
Mhm.
So you can see that my sense of balance is in fall brush. So I'm gonna close my eyes. 1, 2, 3,
doing better.
4. And I go.
So the aim is 10 seconds minimum, right? And the longer you can. So people like us, 30 seconds, 40 seconds is the aim. There's a table with different ages. But you can see how difficult it can be, and you work all those little muscles, the coordination. You don't grow muscle out of it, but you get the muscles used to being active, so that if you ever slip, you can quickly bring your leg and catch yourself, or minimize the damage, so to speak.
So it's interesting when I go to an office building or whatever. I met a 93-year-old lady yesterday, that usually goes down to, she lives in an apartment building. They have a nice gym. The elevator is broken, so she's 93 and she walks down and up 8 flights of stairs on a regular basis.
Yep, exactly. That's why stair climbing is a wonderful exercise. It's aerobic, a little bit of resistance, and a lot of balance going up and down.
You go to the clinic, take the stairs, not the elevator.
You should put a sign.
Brad, I think you're gonna need to make a new Health Olympic graphic. John beats Dr. Curry with balance exercise.
Oh wow, I'm surprised. I'm surprised. Do we time it? Didn't time it.
We'll
Maybe
have, we'll
next
have to
time.
work on it.
Yeah.
These are things
All
we-
right, all right. Great. Now, speaking of stair climbing, we have the CN Tower climb. John, feel free to join. We have a 95-year-old Hambletonian who was the oldest person last year. People take their time. I took my time. So anybody up for a challenge, it's happening in April. The dates are here, and also in October. So there's 2 days they have. And the dates
will
are all
go-
Saturday and Sundays. Yeah.
My wife and I are in PAI for the month of April, and we're in
Okay.
New Brunswick for the month of May. So maybe in the fall.
Maybe perhaps in the fall, of course. And we're gonna have a
Good luck.
local walk in the clinic as well. Local 5K jog, walk, run for people to come. We can also do that. Yeah. Around the clinic somewhere, park in Hamilton. Yep. All right. Now the go, Dr. Kearney. You probably know more about this one. Tell us about this.
Yeah, so these are from retiring webinars. So at what age you're going to retire and things of that nature, something called the go-go years. And so those are usually between the ages of 65 and 75, where people are able to travel and do more. After 75 years of age, people start to slow down and develop illness. And one of the problems is getting insurance becomes an issue, and also just having the ability to travel. So I think we all, or many of us, want to travel, and you're traveling. So is that think about that. And so I'm really becoming more conscientious in how hard you want to work, what you want to do, how much fulfillment you're getting, what hobbies that you want to do, and then is that you showed us a slide that the life expectancy of a 65-year-old is basically just under 20 years. We also know from insurance tables that your travel time is between 65 to 75, and we all think we're immortal. We're not. But there are many steps you can do to prolong that, and we're going to talk about that right there. So I think that's really, really important to that. So that's something important. Next slide, please.
Yes. Oh.
Yeah, great, Lauren. Sorry.
Yeah, all good. Yeah, so we're going to talk a bit about John's travel experience. First, besides all the fun part, maybe it's important to talk a bit about the challenges associated with travel insurance, especially if you have heart problems, and stuff like that. Do you kind of want to share your experience and what you kind of look out for when you're traveling?
We're traveling in Canada. We cannot get travel insurance to go outside of Canada. It's very expensive, and we're not even guaranteed that it would be applied. So if something happens, like if I have another heart attack, I don't know I'm not confident that insurance would cover it. And besides, we love being in Canada. We have no desire to go outside of Canada. Okay. By the way, that slide is the slide of we had a cottage on Rice Lake. We had that for about 4 to 5 years. Before that, that's when we had a trailer. We pulled that trailer from before for 5 years. We actually with pulling a trailer and having a stationary trailer, that was about almost 20 years. So, but now we just travel by car and we go to the Maritimes and we stay for a month at a place, and just the two of us, and we enjoy it immensely.
Yeah, that sounds great. And this photo is also very nice and cozy. But yeah, despite all the challenges associated with other, like leaving
Mhm.
Canada, as well as wanting to find a hospital and be close to one whenever you do travel. But yeah, still you're able to enjoy your life and travel with your wife. But yeah, any future travel plans?
No, but we'll just travel to the Maritimes. We like going for like a month or 2 months. If we go to
Mhm.
West, I mean, I would love to go to Vancouver Island, back to Vancouver Island. But that means we have to fly. Because we won't drive. We would have to fly, and no, it doesn't work for us. I've been very, very lucky, very, very lucky in terms of we've traveled across Canada many times. We've traveled in most of the states. So I've done a lot of traveling. Right now, I'll just stay in Canada.
What,
That's
what, what are these pictures of, John?
Well, the one is Peggy's Cove on the left. I'm not sure the right one.
That reminds me of St. John's. I don't know if that's St. John's or not, but
It's either it does look like St. John's because we've stayed there. Either St. John, Newfoundland, St. John in New Brunswick, or St. John's, Newfoundland, one or the other, but I'm not sure on that slide.
nice, beautiful picture.
Yes.
Yeah.
Beautiful. You did not take these photos, by the way, right?
No, I found these ones online just for,
Okay.
maybe John is a photographer at heart.
Yeah, good to move on.
Okay, yeah, so John, do you have any health goals currently or for the future, or are you just gonna keep doing what you're doing?
I'm going to continue doing what I'm doing
For as long as you can do
as
it.
long as I can do it.
Great.
And by the way, that slide that says about the my wife and I, we're hoping for another 5 years of traveling.
Yeah,
So you're still in the beginning of the go-go years, in the middle.
Our goal is to get John to be the longest living patient. One thing I do have, I think the longest living heart transplant patient so far. And I think there are many steps you can do to do a pathway. Live life to a max, enjoy life. Don't put off things. If you are going to do something, do it. Don't put it off. Today's the day, not tomorrow. I love that quote.
That's a great quote.
And I think, is that we are procrastinators. We'll always say, we'll do this next time. Enjoy the moments. I think young people, when you first start off, you self-sacrifice for the future. As you get older, you want to enjoy those moments because you don't know how many great moments you'll still have left.
That's so true.
And I think also too is that we're blessed in our clinic with all these young superstars that have really made a huge difference. So thank you all for all you've done. What other words of wisdom you have on these slides here? We have a few other things to show you.
I think anything else we have, Morgan? Oh, we have some good pictures. Yeah.
Yeah, so thank you so much for sharing your story, John.
Thank you.
Yeah, just have a really great story of just how you kind of bounced back from having that heart attack to just maintaining your health. I think it's really great. Anything else you want to share to the audience, like advice or anything?
No, just live your life.
And surround yourself with loving people. Try to make them better. They'll make you better. And explore and be curious and learn new things. That one of the things I learned is to delay Alzheimer's disease is to basically walk and to travel and to put new thoughts into your brain and things of that nature. Brad, do we want to show any more slides, or do you want to end it at this point in time?
I'm not sure if do we have anything else, Morgan?
It was the medications and exercise group, but I think we're good.
Just go the next couple of slides. I'm just going to show a couple of things. So this is what you can achieve.
Oh, we have this one. Yeah, you sent me this today. Yeah.
This is a gentleman that I've known for a long time as well. You can see he has his health binder. He does his exercising, and he keeps track of himself too as well. And he's another guy that's going to compete with you to 100 right now. Next slide, please. So these are really important. So nothing has changed. It's not something you want to say. This is what I'm doing right now. We all make mistakes. I make mistakes. Again, getting your medications right and not running out of things is important. Next slide, please. And keeping track is important. Pharmacists are having trouble keeping track of things. We do have a number of really fantastic sessions. This is the Wednesday group, and to me, this has been really from a personal perspective. I learned a lot. I thank Jerry, Dia, and Hannah for really leading this group and taught me so much how to become closer to my inner feelings and to enjoy the moments. Next slide, please. We have our Tuesday groups as well for weight management. Next slide, please. Really, if you really want to really build muscle, there's a program called the PACE program. These are done by a lot of the kinesiology students from the McMaster. The difficulty is parking there. They're but they do have they're 9 to 5 type of thing. They have bankers hours, but they're really well versed to help from fall prevention. I feel like I have to practice on my foot. I surround myself with people from squash to tennis to mini triathlons to weightlifting and things of that nature. And I'm blessed with a wife who's much more physically fit than myself. And one of our religions is vitamin E for exercise. And I hope you learn from that. I forget, do we have any more slides here at all? Let's take a look what's next.
We have this group as well.
Yeah.
And the other group that we have online, wonderful channel for people who want to exercise indoors. It's called Yes to Next. Both of our weight loss team and our mindfulness exercise teams love this channel. If I'm not mistaken, they're not in Canada, but they started during the pandemic and lots of people love them. So it's just an amazing resource for people. Yep.
Yeah, I like it. There's they're basically an older and a younger person. They're all exercising together.
Daughter and mom, yeah.
They're fantastic. Next slide, please. So
And that's it.
okay,
Let's
just
go back
let's go back to this young guy over here. Let's go back to John again. John is a wonderful man. He makes what medicine's all about. You see people when they're having a problem, you make the right diagnosis, you get the right therapies. And more importantly is that John's part of our family, our health family. He's a real pleasure to look after. He's working hard on prevention, and he makes those around us better. He did a wonderful job in his teaching years. He's taught me a lot. And you, Rad, Lauren, and everybody else in this clinic has taught me so much. And I appreciate everybody's hard work. Morgan's here, really making things work. And to make all this stuff run smoothly requires a whole team approach. And so being a health provider is a wonderful opportunity, but it's also a scary opportunity. Don't mean to scare you with numbers, but we in healthcare think about what can go wrong, how to prevent that. You in health talk about ignoring the problem, so we have to find that happy medium. So my hope is that John and I will be celebrating his 100th birthday party together, and we'll beat the odds that 85 will blow way past that. And there's a good chance that with all things happening, that we're going to even longer than expected. But you never know when you're going to see that big cancer word come to play. You get a bad infection, or you have a bad accident and break your hip. And so these are things you can do. So enjoy the moment, be healthy, and take steps to keep yourself healthy. And I want to thank John and the whole team for putting this together. Any final thoughts from anybody?
No. Thank you very much.
Have a great night. And I think what I'm going to try to do is going to do some stairs tonight. I'm going to go. I haven't been stairs for a while there. I might go to the Shadok stairs for a little bit on the way out, and then go home and go to bed. I have to be at my Dundas physio tomorrow morning at 6 o'clock, and I got a couple things left to do over here. So thank you so much, and great night, everybody. Thank you for listening, and thank you for sharing, John.
Oh,
It's been a
thank you.
real pleasure to be involved in your care. Can I give you a big hug?
Of course.
Thank you so much. And Morgan, thank you so much. And
Yeah.
perfect. And
By the way,
and-
one of the things always good. You always learn. You're always learning things. And my change because I told Martin I play bridge a lot, and I also do Sudoku. But now I'm going back and I'm doing jigsaw puzzles.
Nice.
Just something to keep you active.
Perfect.
Yeah.
Have a great night, everybody. We'll see you next time. Good night now.
Good night.
Everyone. Bye bye.